Very well, it's time for your health segment, and our focus, of course, of discussion is today the cost of treatment of cancer. Remember that, of course, cancer is ranked as the third leading killer disease in Kenya, and of course there have been calls for the government to declare cancer a national disaster. And one of the issues that Kenyans continue to grapple with, even as the government talks about affordable healthcare, is whether indeed it is possible to reduce the cost of cancer, and what are some of the ways which we can be able to address this. Of course, that is what is forming the basis of our segment tonight, the burden of cancer financing and treatment. What are some of the options that we have when we talk about cancer? And to help us digest and understand more as regards this particular topic today, we are joined with Julia Ouko, who is the Principal Healthcare Contracting at the National Hospital Insurance Fund, as well as Dr. Alfred Karagu, who is the Director for the National Cancer Institute. And of course, the National Cancer Institute is the coordinating body for all cancer control activities in Kenya. Thank you both for coming to our studios this evening. All right, and I want to start with you, Dr. As the coordinating body of cancer control activities in this country, what is the burden of disease, the burden of cancer in our country as we speak?
Thank you for having me. Cancer is a significant burden in this country, contributing to, as you rightly said, accounting to about 7% of our total mortality. We see about close to 39,000 new cases per year, and we also see about 28,000 deaths. So that is a concern, because that means that more than half of our cases end up succumbing to the illness. It's really something that we need to do something about as a country, and I think as an institute we are working very closely with various stakeholders as a coordinating body, so that we pool our resources and together to make sure that we have a united front towards addressing this burden. Yes.
Of course, there's been a push for us to declare cancer a national disaster. Do you think we are at that point?
I would say probably yes, because I think from what we have seen in the experience of other ailments, when something has been declared a national disaster, the advantage of that is that it's able to attract resources. Yes. I mean, it's sort of like a unifying factor for people to come together and forge a common front. And that is important, because when you look at cancer, is not a simple ailment like your malarias, your TB, and so forth, because it's a whole continuum. There's a whole journey. There's an element of screening and diagnosis, an element of treatment, the element of palliation. So all those elements require quite a bit of resources. So for me, I think it's a good conversation to have in terms of us trying to figure out how do we bring together stakeholders how do we put resources. So I think that probably is a good way to approach the burden that we have as a country. Okay. Yes.
Julia, of course, one of the things that the government is trying to do is to make sure there is access to, medical care. And particularly, I want to talk about medical insurance under NHIF. What is the uptake as we speak, before we focus on what you offer when it comes to cancer treatment? Are people responsive towards registering for NHIF?
Okay. Currently, as we stand, we are looking at 7 million principal members. So if you do a rough calculation times 3, because we're looking at a family, a spouse, and a child, we are facing about 20 to 21 million Kenyans covered.
And so that's like about half of the
population. We are going there. And because of the access to healthcare and the Agenda 4, and the fact that we are supposed to bring in everybody so that we can access affordable healthcare as announced, our registration division is out there ensuring that everyone is registered, pools are coming in, and most of the Kenyans get covered. So I would say the uptake of NHIF cover, or insurance, public insurance per se, is good, and it's something that is ongoing. And
in terms of patients who have cancer, what access do they have in terms of what are you able to treat them for?
Okay, you see, cancer, when you approach cancer, cancer has basically 3 protocols of treatment, and you're either going to undergo surgery, surgical treatment, you're either going to go through chemotherapy intervention or radiotherapy. So NHIF is financing all. If your cancer requires a surgical intervention, we come in with our surgical package comprehensively. If it requires chemotherapy, whether it is first-line treatment or second-line, even that we cover. If it requires radiotherapy, so we are in cancer management as a whole. Yes.
But how much is it that, you know, you can cover a person? Because we've seen incidences where people, yes, you have medical insurance, but you're told, you know what, your insurance is exhausted, you still need more money, because cancer is not cheap to treat.
Correct.
So when we talk about money, what are the estimates for the different levels?
Okay, so for surgical cases, they go through pre-authorizations. So once the hospital knows how much it's going to cost, they place the request and we approve. So it's based on a myriad of things when it comes to surgery. You can never tell how much they're going to bill you for surgical. But when it comes to chemotherapy, we have board-approved rates. When it comes to radiotherapy, we have board-approved rates. So we are looking at sustainable financing. We are looking at, when, for example, we are managing cancer through first-line treatment, we cover up to 6 sessions, 25,000 per session. When we enter into the second line, we cover up to 4 sessions of 150,000. If it has to be radiotherapy, we do 20 sessions of radio at 3,600. So when you look at it comprehensively, it's over 800,000 that we pay for a patient who's been diagnosed with cancer.
But of course, is that, you know, Dr. sufficient to treat cancer?
Well, I would say it's a good step. It's a good step, but probably not, you know, I think from what you have seen, it's not able to cover all the elements that are required. For me, I think when you look at this in the context of the larger, you know, universal healthcare, you know, agenda,
yes,
it's a good step that we have started as a country in terms of having insurance, you know, being able to cover cancer treatment, because I think not very many countries in the, you know, many developing countries are able to do that. So I think the first thing is a good step, because what we know is that cancer, just like many other non-communicable diseases, has the capability of impoverishing, you know, our societies, our members of the community.
Yes.
So I think it's a good start that NHIF has done. So using that, then we can, and since we have lessons learned from there, and we have started seeing what some of the gaps that are there, because like, well, she has talked about there's a cap. Sometimes they're only able to provide up to a certain number of cycles.
Yes.
So now that we have seen, we have that experience, it's much easier now for us even to start advocate when we engage with treasury, when we get with other players, to start and advocate to them about the need now to bridge the gaps that we have already observed from what has been able to be done for the past few years. But I think it's a good step.
But yes, the perception that treating of cancer is easier, the cost of treatment is easier in India as opposed to Kenya, is it factual? Do you think that is the case, or it's more of a perception?
I think it's a mix of both. I think probably where the advantage that India has is that I think they're able to leverage on you know, their well-established capacity, and they're able to leverage on, because they have a fairly well-established capacity, they're able to accommodate volumes. So like the way I think our capacity is fairly limited, so we aren't able to, you know, to be able to have the efficiencies of having many numbers. So to some extent, I would say probably that's why some of the services, like for example, something like a PET scan. PET scans is not available in Kenya, so it's easier for it to be available. I mean, it's cheaper for it to be in India. But for some other services, I think the rates are actually comparable. And sometimes we even our argument is that there are other because for services that are equally available between India and Kenya, for example, there are other added advantages of having your treatment in Kenya, because, you know, there's family support, society, you don't have to travel. So that's why I would say it's a mix of both. For the services that are equally available here and India, I would say it's probably a perception, but for services that are not available here in Kenya, then it's actually true that those services are cheaper, in India as compared to here.
All right.
Yes.
As NHIF, how efficient are you in terms of, when someone needs you to pay up your bills? Because there's always the perception that NHIF is slow, and then they want to lock you to certain hospitals to be able to access treatment.
Zeroing in on cancer, not many hospitals in the country provide cancer management. Currently, we are looking at close to 30 hospitals that are contracted to offer full cancer treatment.
Are they spread out across the country?
They are spread out in the major towns. And that's where you will find our oncologists. So that also brings us down to the human resource aspect. We do not have enough oncologists for the diagnoses we are seeing. Current data from Ministry of Health says that we get about 40,000 new diagnoses every year. But what is the increase in response to the human resource capacity to handle that? The healthcare facilities to handle the same. So the ones that are able to provide cancer management, those ones are contracted for the benefit of our members who have to access them for treatment. We are really not slow. We are quick, we are efficient, we are real time, and we get, the moment we are notified, we are able to approve and the member continues on the treatment, because it's a whole system of approvals, it's a whole system of forms, it's a whole system of verification and confirmation, but it is efficient enough for cancer treatment and management.
All right, in terms of our priorities, as you know, the National Cancer Center, Institute rather, what areas are you prioritizing when it comes to cancer financing? What areas would you prioritize?
Well, I think first of all, I would want to say that as the National Cancer Institute working with other organs in government, last year we actually launched our National Cancer Control Strategy. So what we did is that we identified 5 key areas, 5 key pillars that would help us in terms of addressing the cancer burden. So the first pillar is on issues around screening, early detection, because we realize that the bulk of our cases, will be in advanced stages. So the other area that we are focused on is actually now actual diagnosis. And the third element is the issues of treatment. And around treatment, I think one of the biggest concerns we have is the cost of treatment. So one of the ways that we are trying to and we're working very closely with the KEMSA, because we realize that one of the reasons why particularly the cost of medication has been so high is because as a country we have not been procuring cancer medicines in bulk. As we speak right now, we have early this year we actually developed a priority list of our essential medicines, like what would say the top 50 or 60 molecules that we want to as a country to use as our priority medicines, and KEMSA is currently in the process of procuring that.
So are we likely to see the costs coming down?
Yes, I can tell you that. For sure, we will see costs coming down. And also aligned to that is that we have also been in very close engagements with the private sector. I know we are adopting a PPP arrangement to because I think the argument we are making to the private sector is that when we procure in bulk, so that we are able to supply our 2 referral hospitals, and we actually looking to have about 10 other county referral hospitals being able to provide chemotherapy drugs. So when you're able to procure for all those facilities, then you can assure them higher volume, so they don't have to have as high markups as they are currently having. So that's how we are prioritizing the area around treatment. Another key that we are prioritizing also is research, because we appreciate that we don't have well-documented research in Kenya. So currently what we are doing is that we are actually doing a systematic review of the research that has been done over the years, so that we have a baseline. Where are we? So that even as we move forward, even as we start identifying the areas that we want to start investing in terms of research, it's informed by what has been. So you're
still trying to find out which areas you need to prioritize when it comes to research.
Yeah, I think, it's what we have, what we have done is that we have done the systematic review. Actually, we have actually gone into our electronic databases. We are targeting repositories in our universities, because we realize that master students and our doctoral students are doing research around cancer. That's actually ongoing. We have actually been able to highlight about, I think there are about 190 or so papers around cancer in Kenya. So we are trying to, so that is probably in the I would say with a timeline of around August, we shall be able to have a very clear understanding of this is what has been done in terms of research in Kenya. These are the gaps. So when we are trying to now to see where to put the money, then we'll have a very clear justification of what is required. Okay,
we are almost running out of time, but I want to come back to you, Julia. In terms of limitations and restrictions, what should patients know about the NHIF cover?
The NHIF cover, as it is comprehensive. So when you're diagnosed with cancer, come out. If you're a member, come out. If you're not a member, look into ways and become a member. Get registered, be a member. Then you'll be able to access the full range cover that we have brought in through surgical intervention, chemotherapy, and radiotherapy. So for Kenyans, we would encourage them to enroll to be members of NHIF and come out and access the packages that are there specific for cancer treatment. But even as we encourage them to come out, government would help us in bringing out the promotive preventive aspects, early diagnosis, screenings, and that would make even the management and the cost of care to reasonable levels. Because we are keen on sustainable financing, prudent management of resources in cancer management. We also want policies and regulations when it comes to medication. The cost of medication is ballooning, nobody is controlling it. Our human resource is also not up to the numbers that we are seeing. So it's a whole play in the health system. Our pillar is just to finance, but we need the entire health system to be worked up so that it's ready for the increase in numbers that we are seeing in cancer. Research is also key. We need to know why is cancer rising up. And also government putting in on the financing, stepping in onto the financing, so that it's not only members who are financing their treatment. In terms of remittances, are members remitting on time, or that is an issue for you as NHI? For those who are on employment, they are okay. But for the voluntary ones, the remittances come in. We would not say they're late or they're early, but they're there. Yes. They are not. It's not a challenge that you're living with. It is a challenge, because you find there are those adverse selections, there are those adverse effects, and somebody would remember, oh, I have NHIF, let me go pay because this diagnosis has now come up. So there are those hazards, moral hazards that every other insurance faces. Yes. All right, as we wind up, in terms of embracing technology as NCI, perhaps what is it that you're doing when it comes to creating awareness as regards cancer and treatment?
I mean, in terms of creating awareness, what we have specifically done is we have developed materials. Like, last year we launched some educational materials that empower our communities with issues around cancer, like what are the common signs and symptoms, how can you prevent yourself from cancer. So there's material that can be distributed to the general public. We have also developed a module because we are leveraging on some of the systems within the health sector. Within the health sector we have a cadre of people we call community health volunteers. These are people within the community. They live with, they're able to interact with the community. So we have there's a module that we have developed to train them, so that as they're interacting with the community, they're able to give them more information on cancer. And finally, I think about technology. One of the areas that we want to, one of the ways that we want to really embrace technology and use technology to help us is in terms of doing our cancer registration. Because we realize that even some of the figures that we are working with are more of estimates than, so we are trying than the actual figures. So we are using technology to be able to register and be able for our facilities all around the country, so that they're able to report more on a real time, more on a accurate, more complete data. So those are some of the areas that we are trying to use technology on. And finally, also some of the materials we are working with. Like we have had discussions with AMREF to see how some of our training material can be incorporated into e-learning material, because that is much easier than the traditional face-to-face kind of capacity building. So those are some of the areas that we're exploring. Okay,
Josephine, your last words as we wind up the show in terms of the uptake of NHIF and perhaps what you'd want to tell the public as regards treatment of cancer under your cover. Okay, under our cover as NHIF cancer package, we have learnt lessons ever since we rolled it out 3 years back, and we are enhancing it as we discover the changes in regime, because each regime and each protocol is different. So that needs to be taken into consideration. We encourage Kenyans to come out. We encourage our government to help us to do preventive, promotive, to do screenings. We encourage Kenyans to be taught on how to take care of their bodies, the nutritional aspects. But when you are diagnosed, it is stressful enough. Come out there with your good attitude, get your treatment, access the care that is there. Yes, because even attitude affects the outcome of your treatment. Okay. So we are there as NHIF for cancer treatment and management. We are open to changes, we are open to new regimes, we are open to financing it comprehensively for the sake of the Kenyans. All right, thank you both. Julia Ouko, Principal Healthcare Contracting at the National Hospital Insurance Fund, as well as Dr. Alfred Karagu, the Director for the National Cancer Institute. Just put it into perspective, what are some of the things that they're doing as the different government bodies to ensure that at least there is access to cancer treatment, given that one of the big 4 agendas by government is affordable healthcare. And these are just some of the things that they're doing towards the issues of cancer treatment. This is where we put a cap on your health, but business news is up next, so stay tuned.